September 1944. A field hospital somewhere in liberated Belgium. An SS Obersturmführer named Karl-Heinz Brenner, captured 3 days earlier near Liège, is sitting across a table from an American medical intelligence officer. He has been a prisoner long enough to calm down. He is not a stupid man. He spent 4 years on the Eastern Front. He has seen everything, or he thought he had. The officer places a small cardboard box on the table between them. Inside is a morphine syringe, a glass tube, a short needle, and a small wire loop. The officer explains what it is. Every American infantryman carries 2 of them in his first aid pouch, next to his bandages, standard issue. Brenner picks it up, turns it over, and says nothing for a long time. He does not say anything because he is thinking about a question he cannot answer. He has watched American soldiers take hits that should have stopped them, gut shots, leg wounds, sucking chest wounds, and keep moving. He reported this to his battalion commander. His battalion commander reported it upward. Nobody had an explanation that fit. The morphine syringe is not why this story matters. It is where the story starts. Because the syringe is just one piece of something the German Medical Corps, for all its technical excellence, never understood they were missing. This is the story of what the United States did to the problem of keeping a wounded soldier alive between the moment he was hit and the moment he reached a surgeon. It begins not in the Second World War, but in a Civil War hospital in Washington, D.C. in 1862, where a woman named Dorothea Dix was watching men die of wounds that should not have killed them, not from the bullet, from what came after. Before we go back to 1862, I need you to understand what this story is actually about. It is not about medicine. A morphine syringe is 1 cent of materials and 2 minutes of training. It has no strategic value on a balance sheet. It cannot move a division. It cannot win a battle. And yet the United States of America, in the middle of the deadliest conflict in human history, built a medical evacuation system so thorough, so layered, and so fast that soldiers who had been shot through the lung in a Normandy hedgerow were on an operating table in England within 6 hours. Not because America had better surgeons than Germany. Germany had extraordinary surgeons. Not because America had better drugs. Germany had excellent pharmaceuticals. Because America had built a system that connected the man bleeding in a ditch to the surgeon in the hospital as though they were a single continuous operation, and the Germans, who had been fighting wars professionally for 200 years, had never thought to build it the same way. The German military medical system was not negligent, it was not cruel. In many respects, it was technically superb, but it was built around the surgeon, not around the soldier. It was built to treat the wounded who arrived. The American system was built to find the wounded, stabilize them in the field, move them rapidly through a chain of care, and deliver them to a surgeon in the best possible condition. That distinction between a system that waits and a system that reaches is the entire story. Dorothea Dix was 60 years old when the Civil War began. She had spent the previous 20 years reforming mental asylums across the United States and Europe, documenting conditions, writing reports, lobbying legislatures. She knew how institutions killed people through indifference and poor organization, not through malice, through the assumption that whoever died would have died anyway. She was appointed Superintendent of Army Nurses in June 1861. What she found in the field hospitals shocked her less than what she found in the system behind them. There was no system. Men were wounded at Bull Run. They were carried by their friends or left in the field. If they survived to reach a regimental hospital, they were treated by a surgeon who might or might not have seen a gunshot wound before the war. If they survived that, they were transported by whatever wagon was available on roads that had no suspension to general hospitals in Washington that were frequently overcrowded, understaffed, and running out of supplies. The mortality rate for the Union Army in the first year of the war was not primarily from battle. It was from infection, from shock, from wounds that became fatal during the hours or days they went unattended. Dix could not fix all of this. She fixed what she could reach. She trained nurses, she standardized supplies, she pushed for ambulance reform. The man who carried her work into organizational doctrine was a surgeon named Jonathan Letterman. Letterman took command of the medical department of the Army of the Potomac in June 1862. He was 35 years old. He had 11 years of experience as an Army surgeon in frontier postings where the nearest hospital might be 100 miles away, which meant he had learned to stabilize patients in the field because there was no alternative. Letterman looked at the chaos of the first year and did something that no American military medical officer had done before. He designed a system, not a hospital, a system. The Letterman system divided medical care into 3 distinct echelons. At the first echelon were the regimental musicians, detailed as stretcher bearers, trained to apply dressings and move the wounded off the battlefield. At the second echelon were the division field hospitals, far enough to provide immediate surgery, but far enough back to be out of direct fire. At the third echelon were the general hospitals, fully equipped, staffed with specialists, connected to the railroad and the river supply lines. The system was first tested in full at Antietam on September 17, 1862. In the bloodiest single day in American military history, the wounded were cleared from the field within 12 hours. At First Bull Run the year before, some men had lain in the field for 3 days. Letterman had reduced the time from wound to treatment by a factor of 6, using no new technology, no new drugs, no new surgical techniques. He had used organization. The United States Army did not forget what Letterman built. It remembered it, studied it, revised it, and by 1941 it had built something that Letterman would have recognized as his own work, expanded to industrial scale. The modern American battlefield medical system that entered the Second World War was built around a concept that has a technical name but a simple meaning. The concept is forward resuscitation. It means that you do not wait for a wounded man to reach a hospital before you begin treating him for shock. You treat him where he falls, or as close to where he falls as you can safely reach. The primary vehicle for forward resuscitation in 1944 was a 3-man team called a Rifle Company Aidman, more commonly known to the soldiers he served as the medic. The medic carried in his musette bag items that did not exist in the German enlisted medical kit in the same configuration: 2 morphine syrettes, 12 sulfa tablets, sulfanilamide powder for wound dusting, battle dressing, tourniquet, plasma albumin in a tin. The morphine was the most important innovation for forward care. The syrette was designed by the Abbott Laboratories in North Chicago specifically for battlefield use. It was foolproof. A soldier with shaking hands, in the dark, after being shot, could find the wire loop on the cap, pull it, twist off the cap, and inject the medication into his own thigh through his uniform. No needle to uncap, no dosage to calculate, one squeeze. The German Army issued morphine to its medical personnel. It did not issue it to individual soldiers as standard kit. The distinction sounds small. It was not small. A German soldier who was hit and alone and in pain waited for a medic who might be serving 20 men across 300 meters of hedgerow. An American soldier who was hit and alone self-administered within 2 minutes of being wounded. He was alert, not screaming when the medic arrived. The medic could assess the wound, apply the dressing, note the morphine dose on the soldier's forehead with a grease pencil, and move to the next man. The German medic arrived to a soldier who had been in shock-accelerating pain for however long it took to find him. Every minute of pain in a serious wound degrades the body's ability to survive. This was not unknown to German medicine. The Wehrmacht's medical corps knew the physiology of shock as well as any army on earth. What it had not done was institutionalize the solution at the individual soldier level. The American Army did. Behind the medic was the battalion aid station. In doctrine, it was placed 500 to 1,000 yards behind the forward companies. In practice, it was placed wherever the battalion surgeon could find cover and a flat surface. The battalion surgeon and his assistants performed no major surgery at the aid station. The purpose of the aid station was not surgery. It was sorting, stabilization, and speed.
The medical term is triage, from the French word for sorting. The concept existed in German military medicine and in British and in Soviet. What the American system had that the others did not have in the same degree was plasma. In early 1941, the American Red Cross began collecting and processing blood plasma on an industrial scale. The Blood for Britain program had already shown that processed plasma could be stored, shipped, and administered without cross-matching blood type. The American Red Cross by 1942 had collected 13.3 million pints of blood from donors across the country. The plasma processed from this blood was packaged in 2 tin kits, a tin of dried plasma and a tin of sterile water that could be opened and administered in a foxhole by a man with 15 minutes of training. Plasma does not